The meeting is called to order. Silent prayer.
Now flag salutation. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, long live IMA. Now I would like to invite Dr. IMA Joy, President, Thrissur Neurological Society, for the welcome address.
Respected members, my wish to welcome you all to this meeting which we are conducting in commemoration of the World Epilepsy Day. It's being celebrated International Epilepsy Day. So we got two talks today, one by Sachin Sudesh Babu from Kozhikode MIMS, and one by our own Prashant Varghese. We're talking on various aspects of epilepsy. So I first of all invite Dr. P. Gobi Kumar, Senior Vice President of IMA Kerala State Branch, to this meeting. And I also invite the two speakers, Dr. Sachin Suresh Babu, who is speaking from Calicut. He is a Senior Consultant in Epilepsy at MIMS, Asta MIMS at Kozhikode. And also Dr. Prashant, who need not be welcomed, but he's our member. So, but I just welcome him also to the meeting. And we have our chairperson, Dr. Baiju from Medical College Thrissur, and Dr. Narayan Nuni, who is Secretary of TNS. And Dr. Firoz Khan, who is the moderator. So I welcome him also to this meeting, and I welcome you all to this World Epilepsy.
Thank you, Dr. Joy. Now I invite Dr. Joy Manjula, sir, for the presidential address.
Good evening to all. Today's respected Chief Guest, Dr. Gobi Kumar, we had planned it earlier, but all of a sudden yesterday, National IMA has called him as moderator. So he may not be able to come, but instead Dr. Jain Chiman will be the chief guest. I welcome him. And today we are observing World Epilepsy Day, which actually falls on 17th of November. That is National Epilepsy Day. Due to some technical problems, we have postponed to today, 30th this month. And I hope we will have a very informative and excellent CME today. I'm not prolonging my talk. Thank you all.
Thank you, Joy, sir. Now I would like to invite our chief guest, Dr. Jain Chiman, Central Working Committee member, for the inauguration.
Today we have two Joys on the dais. One Dr. Joy, MA Joy is the president of Neurological Society, and Joy Manjula is definitely our own president. So it's a great honor in absence of our senior vice president, Dr. Gobi Kumar, who is held up in a national seminar, to again inaugurate one of neurological one CME which we are going to conduct along with the Neurological Association of Association. last year, I still remember we had, I think, 3 or 4 combined meetings with Neurological Society. And again, when we were actually relaxing that almost the main COVID is over. Now again, another version is going to come. So again, we will be definitely having only online CMEs or mainly at the most hybrid CME. So I congratulate Thrissur IMA for coming forward with such a CME. They are conducting it regularly with all sister specialty organization. And today we have got a very good faculty lined up for discussing today. And the topic is very useful for all of us, for general practitioners. So I wish all CME, I wish the CME all success. And I officially inaugurate today's CME. Thank you.
Thank you, Dr. Jain, for inaugurating this session. Now I would like to invite Dr. Andrew T. Joseph, Chairman, IMA CGP Thrissur, to address us.
ബഹുമാനായ ഇന്നത്തെ ചീഫ് ഗസ്റ്റ് ഡോക്ടർ ജിമൻ സോറി എൻ്റെ സ്റ്റേജിലും സദസ്സിലിരിക്കുന്ന പ്രിയ ഡോക്ടർമാരെ, അതുപോലെ തന്നെ സൂമിലിരിക്കുന്നതായ ഡോക്ടർമാരെ, IMA തൃശ്ശൂർ ബ്രാഞ്ചിൻ്റെ അക്കാഡമിക് വിങ്ങായ CGPയുടെ രണ്ടാമത്തെ മീറ്റിംഗ് ആണിത്, CME ആണിത്. ആദ്യം നമ്മൾ കഴിഞ്ഞ മാസം ഒന്ന് നടത്തി. അത് അപ്പോളോ അഡലക്സ് ഹോസ്പിറ്റലുമായി സഹകരിച്ചിട്ടായിരുന്നു. അത് വളരെ നന്നായിരുന്നു. അതിൻ്റെ ക്രെഡിറ്റ് എല്ലാം നമ്മുടെ പ്രസിഡന്റിന് കൊടുക്കേണ്ടതാണ്. അതുപോലെ തന്നെ എല്ലാവരും കൂടി സംസാരിച്ചു കഴിഞ്ഞാൽ പിന്നെ ആരും സംസാരിക്കാൻ പറയണ്ടല്ലോ. ഇത് നമ്മുടെ രണ്ടാമത്തെ മീറ്റിംഗ് ആണ്. ഇത് നമ്മൾ തൃശ്ശൂർ ന്യൂറോളജിക്കൽ സൊസൈറ്റിയും കൂടി സഹകരിച്ചിട്ടാണ് ഇത് നടത്തുന്നത്. ഇത് വളരെ ഭംഗിയാവും എന്നുള്ളത് എനിക്കറിയാം. കാരണം നമുക്ക് കിട്ടിയിരിക്കുന്നത് വളരെ നല്ല ഫാക്കൽറ്റീസിനാണ്, അതുപോലെ ചെയർപേഴ്സണെയും. നമ്മൾ എല്ലാ മാസവും ഇതുപോലെ തന്നെ ജനറൽ പ്രാക്ടീസിന് ഉപകാരപ്രദമാകുന്ന ഓരോ CMEകൾ നടക്കാൻ തീരുമാനിച്ചിട്ടുണ്ട്. അതിനെല്ലാം നിങ്ങളുടെ സഹകരണം അഭ്യർത്ഥിച്ചുകൊണ്ട് ഞാൻ എൻ്റെ വാക്കുകൾ അവസാനിക്കുകയാണ്. താങ്ക് യു.
Thank you, Dr. Anto. Now, I would like to invite Dr. PC Gilva, sir, HOD of Neurology, JMMC Thrissur, to address us.
Luminaries of the Thrissur IMA, senior members of the profession, and my dear friends. When Dr. Joy mentioned to me this morning, you'll have to say a few words. I asked him for what? And his answer was, you have arranged everything. But this is the biggest untruth, because in fact, I have begun to admire Dr. Joy. I just give him all the data and he puts it together in the format of a brochure. And I think it's all his work, all his idea, and all his drive in this matter. I think it's a great thing, sir. Then the next question is, I was asking myself, why should we have any day, epilepsy day or stroke day? Why should we have one like that? I think the bottom line is, why do we celebrate a birthday? Now, this is simply because on that day, we think about that person. So also on these stroke day, heart day, etc., we think a little more about that topic. And today it is the day to think about epilepsy. It can be a very difficult disease to handle, but it's a day when we try and spread the message that epilepsy is treatable. Epilepsy is not a stigma. Epilepsy is something which we can live with. This is the most important thing of why we celebrate a day to remember that particular topic. So with these few words, I think we now go on to the next item. I think we now hand it over to the chairpersons, before which I think Dr. Narayan only had the job to do. Thank you so very much.
Thank you, Gilva sir. Now I would like to invite Dr. Narayanan Unni, Secretary to Thrissur Neurological Society, for the introduction of chairpersons and handing over the proceedings to the chairpersons. Dr. Narayanan Unni.
Good evening, everyone. It's a pleasure to be here today, this evening. Job assigned to me is to introduce the chairpersons for the upcoming CME. So we have two prolific neurologists today as the chairs. First is Dr. Baiju, who is familiar to all of us. He's working in GMC Thrissur as the head of Department of Neurology. He graduated from Government Medical College, Calicut in 1990, finished his MD from Medical College, Kottayam in 2006, and then finished his DM Neurology from Government Medical College, Calicut in 2012. He joined as faculty in Medical College, Thrissur in 2001 and worked in GMC Kottayam and GMC Calicut as well. And presently, as said before, he is the head of Department of Neurology in Medical College Thrissur. He is also the president of IMA Thrissur from 2018 to 2021 and Thrissur IMA District Committee convener for the period 2021. Welcome, Dr. Baiju. And next we have Dr. Firoz Khan, who also happens to be my colleague in Daya Hospital. He has very prolific credentials. He finished his undergraduate degree from Kottayam Medical College in 1997. Then his MD from the same college, Kottayam Medical College, 2001. Then finished his DM from the prestigious Sri Chitra Institute in the year 2004. Then he went for a fellowship program in stroke in Calgary, Canada, which he finished in 2007. He worked as assistant professor in Medical College, Kottayam briefly for in 2005, and later also in Lissi Hospital, Kochi. And from 2008 onwards, he is here in Thrissur, working in Mother Hospital as well as Daya Hospital. So welcome, Dr. Firoz Khan. So with these few words, I will hand over the session to the chairpersons, Dr. Firoz Khan and Dr. Baiju.
I would like to invite Dr. Baiju sir for the introduction of the faculties.
I am very happy to attend this function organized by the IMA Thrissur and the Thrissur Neurological Society. So many friends here. I can see so many friends. Dr. Joy Manila, IMA Thrissur President and IMA Midson Joint Secretary. Dr. Jane Chiman, my former leader in IMA Thalapalli, Gopimar sir, and so many senior leaders from IMA and so many senior leaders of Thrissur Neurological Society like Gilva sir, Joy sir, etc. So a good evening to everybody. So let me go to my duty first. So I will first introduce the speakers. We had two eminent speakers here. One is Dr. Suresh Babu. He's a senior consultant and epileptologist now working in Aster City, Calicut. He had a very illustrious career. He was formerly the head of the Department of Neurology in St. Stephen's Hospital, Delhi, and his career is also was very illuminating. When he worked as a student also, he got the Matthew Roy Memorial award for the best outgoing students while he was doing his MBBS. He was the first rank holder in the Kerala medical entrance exam, and he has got the gold medalist in anatomy and pathology and medicine. The other speaker is none other than our student, our dear student Prashant. Prashant, I have been knowing him from his MBBS days. He graduated from Thrissur Medical College, later completed his MD from Calicut Medical College, and went to Srijitra and took fellowship there in epilepsy. So on this day, when we are celebrating the National Epilepsy Day, which was actually due in November 17th, these are the apt persons to speak on this subject. So without wasting much time, I think I will invite the speakers to begin with. So I think who is taking the first one? So Sajin sir, please, you can start.
Okay. I'm trying to share my screen. Is it visible, sir? Am I audible? Is my screen visible? Hello?
Dr. Sachin, it is loud and audible, very clear.
Okay, okay.
Go ahead.
Thank you, thank you. Yeah. Okay, so thank you so much for the invite. And actually, I got the invitation while I was away on a conference, but then the invitation came from Dr. Gilbert sir. So which itself is a huge, it by itself, it's a huge honor for me. So I took up this challenge, but I also feel very nervous speaking before such illustrious people with a vast amount of experience, much more experience than I have. I don't know whether I'll be able to do justice to this topic, which I have titled Art and Science of Choosing the Right AED. And why I call it art and science is that because there is a science to it and there is an art to it. It's not always science. For example, when you look at the way anti-epileptic drugs are chosen sometimes in certain facilities abroad, for example, they may go by pure science or they may go by the guidelines which have been laid down and they will strictly adhere to it and they're very dogmatic about it. But what in India, as our forerunners have taught us, or teachers have taught us, and what we have found in dealing with our patients is that it is an art. It is about choosing the right AED, then finding the right combinations over the years, and then being very flexible and versatile with your treatment so that you get the best result. So how we do it, let us go into it. As we know, epilepsy is a disease with a huge burden, both physically as well as psychosocially, and the treatment gap is very huge. So we want all hands on the deck. We want everybody who is involved in medical care to treat patients with epilepsy, identify patients who require advanced treatment, and at every level there is much work to do. And we know that all of you know the diagnosis of seizure, and it is described as an excessive and abnormal hypersynchronous discharge of population of cortical neurons. And epilepsy refers to a syndrome where a disorder where there is a tendency for recurrent seizures in the absence of a provoking stimulus. So that is what is epilepsy. So whenever you are encountered with a history suggestive of a seizure, it's very, very important that you first determine whether it is a seizure or not. Because many times, even movement disorders, abnormal movements like dyskinesias, dystonias are mistaken for seizures. And we have seen patients with all kinds of psychogenic episodes who are mistaken. Then there is something called as alternating hemiplegia of childhood, which is sometimes mistaken as a seizure. Syncope is the most common condition. And therefore, the history is very important. And once you determine what is a seizure, then you find out a type of seizure, what is the type of epilepsy, what is the type, what is it epilepsy or what type of epilepsy, then what drug, what dose, what duration, all this has to be mathematically and very meticulously planned. So the ILA recommends that first you determine the seizure type, then the epilepsy type and the syndrome. At the same page, you also look at what is the etiology. So etiology determination is very important. And at the same time, you have to work out this, you have to go down the same algorithm, seizure type, epilepsy syndrome. So this is very important. And this is not a one-time thing. For example, you think that there's a particular seizure, there's a particular epilepsy type, you start the treatment, it doesn't work. Every time you ask this question, have I made the right diagnosis? Is it really seizure? Is it epilepsy type correct? Is epilepsy syndrome correct? So there's a constant exercise. And then once you have made a diagnosis of whether it's a focal seizure, generalized seizure, you find out what type of generalized seizure, what type of focal seizures. Now the classification of focal seizures have become very simplified. And I like the way they put it, like focal onset. A focal seizure, or when you call it a focal epilepsy, that is not correct. What we're trying to say is the focal onset. If you can ascertain from the history or from the semiology which is recorded in your lab or from the EEG, a focality of onset, then we are dealing with a focal onset epilepsy. That distinction is very important. And focal onset seizures can be with preserved awareness or with impaired awareness. And depending upon whether they have other accompanying phenomena, we further classify them into different types of focal onset seizures. And most often the focal onset is announced by the presence of an aura. So whenever you take a history in epilepsy, it's very important what happens actually before all the motor phenomena sets in. And most of the patients and the relatives will be preoccupied with the motor phenomenology. They forget to detail the focal onset. So you keep on asking them. You just have to look at the various lobes of the brain to ask the right questions. For example, if it is occipital, you have a visual aura, you have a posterior cortex adjoining to the occipital, then you may have a darkening of vision, you may have a, sometimes you have vertiginous sensation, a tendency to fall, you move further. Anteriorly, you go to the parietal lobe, sometimes you will get out-of-body experiences, and you can even get vertiginous sensations and sensory aura. Then you go further, the motor cortex, you can just directly go to motor phenomena like clonic movements. And when you go much anterior to the motor cortex, you can have tonic movements. And then even much more anterior to the motor cortex, you can have hyperkinetic movements. And when you go to the temporal lobe and the limbic structures, you can have fear, anxiety, ascending epigastric sensation. So all these auras have to be determined. And it's very important to not to forget another structure called the insula, which can produce the aura like, a choking sensation, gurgling sounds, whole body sensory aura. So aura is very important. Always search for it so that you can determine whether you are dealing with a focal epilepsy or a generalized epilepsy, because it is a very important bearing on the treatment. Now, this is the algorithm that we follow. Once the diagnosis of epilepsy, the seizure type, the seizure syndrome is established, that is the point when you start the monotherapy. And this also mandates that you have excluded other paroxysmal events. And remember that your monotherapy is only going to help 50% of patients. You may need a second drug in another 20%, and in 30% of the whole lot, there will be a requirement for advanced treatment like epilepsy surgery. So this has to be explained to the patient from the beginning that I have a roadmap in my mind for you. We have a plan laid up for you. You don't need to panic. If I start this treatment, there's a 50% chance that you will never get a seizure again. But you may get a seizure. And if you get a seizure again, there is nothing to panic because we know what is the next step. And also this the choice of this monotherapy and the choice of the second drug is very important. That is the whole point of discussion today. And once you have found that this patient has failed two judiciously used drugs, you start contemplating about advanced evaluation. Advanced evaluation mainly means to record these events in a video EEG room, find out what is the type of seizure, what is the seizure syndrome, I mean, reclassify, or is it really seizure? Are we treating the patient wrongly for seizures? Because patients who have seizures may, after a long time, develop something called a psychogenic non-epileptic events, and the percent refractory events may not be seizure at all. So once you find out that this patient is having true seizures, you want to know the focality, you want to know the exact part of the brain from which it is occurring. And then you start looking very carefully whether there is a surgical substrate which can be removed so that the patient can be cured of his epilepsy. Now, this surgical substrate determination requires very advanced neuroimaging where very thin cuts of the brain are taken and a 3D reconstruction is done using this images. So that is called as epilepsy imaging. And you must remember that at least 70% of the time when you do an MRI, in a patient with epilepsy, it is going to be normal in a focal epilepsy because the thin cuts only will provide evidence of something like a dysplasia or a mesial temporal sclerosis. So once the surgical substrate is determined, you go ahead with surgery. And if the patient is not a candidate for surgery, you need to still continue trying drugs. And again, this drug should not be chosen randomly according to our own whims and fancies. And that is where we have discussed this art and science. So we know that certain drugs are broad spectrum, certain are narrow spectrum. So just there is a tendency sometimes, okay, this is a broad spectrum drug, why not try a broad spectrum drug? So that's not how it works. So we have to find out the epilepsy syndrome. So focal epilepsy, you go first with sodium channel blockers, and if it is a generalized epilepsy, you consider something like a valproate or a levetiracetam. So that is okay. That's just a very simplistic view of viewing things. And I want to stress and emphasize at this point, there are so many drugs in our repertoire. And if we are going to, some people who are so loyal to certain drugs, like for example, some people will diligently use valproate and condemn anything and everybody who uses any other drug for generalized epilepsy. And somebody will use only levetiracetam, somebody will use only oxcarbazepine and carbamazepine. See, carbamazepine group of drugs can cause a rash, and oxcarbazepine is notorious for hyponatremia. So why do we want to use the same drug in all patients? And I will tell you that if you use the same drug in all patients, this practice itself is going to get very boring. So I wanted to exploit and explore the potential advantages of each and every drug and the synergism that comes with the combination of certain group of drugs. That is going to make epilepsy treatment a lot more interesting. So many times the choice of the drug and the combination of drug is determined by the mechanism of action. That is why the mechanism of action is very important. And you must know that there is a presynaptic neuron and the postsynaptic neuron. There is an inhibitory synapse and an excitatory synapse. In the excitatory synapse, glutamate is the mediator, and in the presynapse and in the inhibitory synapse, GABA is the neurotransmitter. So when it is GABA, then at the inhibitory synapse, you can actually potentiate the action of GABA through many drugs. And among this group of drugs, the most commonly used drugs are the benzodiazepine group of drugs, like especially what we use nowadays is clobazam. But when we go to the another group of drugs, I mean, of course, valproate also will increase the availability of GABA, and drugs like vigabatrin will decrease the GABA degradation, and even other drugs like felbamate, which is no longer in use, can also act through GABA receptors. The glutamate receptor is now being increasingly, the glutamate or the excitatory synapse is now considered very, very important. And sometimes we leave the excitatory synapse totally untouched. So that is something which we have to pay attention to. The glutamate transport or glutamate exit is aided by a receptor called, by a vesicular transport protein called SV2A, and that is attacked by levetiracetam and the newer molecule brivaracetam. And the drugs which act on the presynaptic receptors are mainly sodium channel blockers, and which includes phenytoin and lamotrigine and all. And sonizumab and certain drugs have a broad spectrum acting on multiple areas of this axis. And perambenil is a newer drug which acts very selectively on the AMPA receptors. And these AMPA receptors are very important because the AMPA receptors are the ones which cause the paroxysmal depolarization shift and the rapid burst of potential that triggers secondary generalized seizures, reflex seizures, cortical hyperexcitability. And these receptors are very key. So you must remember that when there is a patient is having epilepsy, most of these acts, most or some of these mechanisms may be going on, and therefore one mechanism, if we address and that patient does not have seizure freedom, does not mean all is lost. You may actually look into another mechanism which may be operating in the patient and then attack it. So that is so very important that every time you choose a drug, every time you combine a drug, we have this picture in mind of this excitatory and the inhibitory synapse. And another thing very important is the epilepsy syndrome. That is why I told you that every time that we look at an epilepsy or a seizure, we have to determine the epilepsy syndrome, because the epilepsy syndrome will help you to choose the right drug. For example, in juvenile myoclonic epilepsy, all these drugs, lamotrigine, levetiracetam, valproate are the preferred drugs. You don't use a sodium channel blocker, which can aggravate a myoclonus. Same thing with rolantic epilepsy. Carbamazepine group can be used, although I have written not preferred, it can be used, but in a small minority at least, it can precipitate worsening and the patient can go in for an epileptic encephalopathy. A Dravet syndrome may benefit from stiripentol, which is not available, lacosamide, ketogenic diet, and the sodium channel blockers actually aggravate Dravet syndrome. So therefore, when we are treating epilepsies in children and the syndrome is there's a chance of epileptic encephalopathy, we have to be extremely careful. And now we are actually entering the era of precision medicine, where these patients should have a very rigid genotyping and phenotyping, and then you choose the right drug based upon electrophysiology, imaging, and genetic characteristics. And the Lennox-Gastaut syndrome may actually benefit from drugs like lamotrigine, topiramate, sonisamide, perimpenyl, clobazam. So this Lennox-Gastaut syndrome group of patients, when I think about 20 years back when I started training, and now we look at this group of patients, then I used to give them always a very dismal prognosis. Bad, there's nothing to offer, that kind of. But now when I started practicing, or when the time came for newer drugs came to the market, I've seen that we encounter success in most of the patients, and sometimes we supplement it with ketogenic diet. We may go in for epilepsy surgery when there is a small substrate which is causing an LGS, and we have also gone for therapies like vagus nerve stimulation. So what I wanted to emphasize by telling you is that an epileptic encephalopathy or even a genetic epilepsy patient should not be just labeled as a bad epilepsy. These patients can benefit from intelligent combination of drugs. Childhood absence epilepsy, we all know valproate, but remember, ethosuximide is now available. And when there is a refractory absence, ethosuximide comes in very handy. And brivaracetam is another molecule which can be used for different types of absence epilepsies, especially atypical absence epilepsies, photosensitive epilepsies also. And then I told you about specific mutations which will benefit from different class of drugs. G1 syndrome, again, we have very good success with sonisamide along with the other drugs which we use for absences. And then we have to remember that there is a class of epilepsies which are immune mediated, like the Landau-Kleffner and the continuous spike waves during sleep. These patients will require, along with the anti-epileptics, immunotherapy, and also rasmusins, which require immunotherapy. Febrile seizures, we only need intermittent clobazam prophylaxis. Melatonin is a new drug, melatonin is now approved for febrile seizures. We haven't used it. And reflex epilepsies and PME syndromes is another, area where we thought nothing can be done, but we have had a lot of success with drugs like sonisamide and perimpenyl coming in. These patients may respond very well to these drugs. And Duce is supposed to respond well to valproate and levetiracetam. And although we say partial epilepsy, we use oxcarbazepine, carbamazepine, sodium channel blockers, and lacosamide and other. But when there is a very high spike burden, it's a specific indication for valproate. Also clobazam, and sometimes the spike suppressing action is good. West syndrome, ACTH and vigabatrin. And if the patient has a difficult to classify epilepsy, arguably you can use a broad spectrum. NFLE, nocturnal frontal lobe epilepsy, topiramate, oxcarbazepine, clobazam, sonisamide. FCDs, oxcarbazepine, perimpenyl, lamotrigine, sonisamide. Posterior cortex is very common in especially in Calicut, we see a lot of posterior cortex epilepsies. Off late, we find, lacosamide, perimpenyl very useful, along with lamotrigine, which is almost useful for all kinds of refractory epilepsies. Tuberous sclerosis, again, vigabatrin, perimpenyl, everolimus. So this is one area, that is, you look at the epilepsy syndrome, try to classify and identify the epilepsy syndrome, then go by the book that this syndrome, this drug. Second is age considerations. You must know that certain ages and certain sexes, you don't want to use a particular drug. When it comes to elderly, we are more worried about fractures, disorientation, try to avoid drugs like that. And when it is in the reproducible age group, it is mainly all about valproate, which can cause a lot of menstrual irregularities and also not preferred for pregnancy. And then, of course, oxcarbazepine is a drug which is very notorious to cause hyponatremia in the elderly. So be very careful with that. So Another thing that should come to your mind when you choose the right anti-epileptic drug is the presence or absence of comorbidities. Now, if a patient is having mood disorder, depression, valproate and carbamazepine group, lamotrigine, very useful. Anxiety, benzodiazepines or clonazepam. Hostility, aggression, try to avoid perimpanel or topiramate and levetiracetam. Try valproate and lamotrigine. For liver disease, of course, you know, valproate, the enzyme inducers should be avoided. For renal, we try to avoid levetiracetam. Dose modification is very important in renal disease. Cardiac disease, those drugs which can cause or precipitate arrhythmias should be avoided. And pregnancy, of course, the preferred drugs are levetiracetam, lamotrigine, oxcarbazepine. Migraine, we know, topiramate and valproate. PCOS, avoid valproate. Parkinsonism, zonisamide and lamotrigine. Ataxia, for episodic ataxia and all, acetaminophen can be useful. Neuropathy, pain, you know, sodium channel blockers. Hyperammonemia, avoid valproate, topiramate. Obesity, weight reducing drugs like topiramate and zonisamide are preferred. Remember, if the patient has a tendency to take reduced quantities of water daily, then try to avoid topiramate and zonisamide, which can produce renal stones. Now, to get you into the thought process and not to just go on dictating the rules and regulations of anti-epileptic therapy, we'll discuss certain clinical scenarios which I hope could be useful. Now, I'm talking about a 21-year-old female with seizure onset at 17 years of age. So she started off having few myoclonic jerks at the time of onset. Then she goes on to have a classical GTCS, infrequent GTCS. And she has this classical frontally dominant spike and wave discharges, poly spike and wave discharges. So we made a diagnosis of, say, primary generalized epilepsy. So she was introduced on levetiracetam up to 1 gram BD, and still she continues to have GTCS once in every 2 months or 1 to 2 months. She also complains of behavioral side effects like nervousness and irritability. She has mild comorbid depression, body weight is normal, no migraine, anticipating marriage in the next year, and family history is negative. Now you can see how many factors are taken into consideration when you introduce a drug. You have to look at the side effects of the existing drug. We have to think about the working diagnosis. What is the diagnosis? Then you look at the comorbidity, the age, the body habitus, you know, the expected events in the next 1 year. So all this has to be taken into consideration when you're going to make it. So sometimes because this patient is already having a lot of events, even on drug. So we are like, it is a good practice to record these events, which we generally do. And these are the classical myoclonic jerks, which are followed by, atonic posturing and it's a generalized tonic posturing, and the GTCS follows. So this is not usually recommended in any patient with GTCS or any patient with generalized epilepsy, but this patient continued to have seizures while on 1 gram BD of levetiracetam. So we wanted to, see whether are we dealing with a focal epilepsy masquerading as a primary generalized epilepsy, which was not the case. And we also recorded the classical picture and the video EG. And after that, okay, the diagnosis is correct. It is primary generalized epilepsy. Patient is a female who is expected to marry in next 1 year. So we did not want to introduce her straight away to valproate. So the best choice we thought was lamotrigine. So the dose of the two things, lamotrigine is safe during pregnancy. Lamotrigine is an excellent drug for primary generalized epilepsy. So we started off, and very important, this patient is having 1 gram BD of levetiracetam. We must all, from the moment that you introduce the second drug, what you have in mind is whether we can get rid of the first drug, because the first single drug is always better than the first drug. And my ultimate aim is that she should be on a single drug, lamotrigine, probably a once daily dosing, so that even if she is married to another home, there they won't question of the 1 drug a day will not cause much trouble. So, okay, levetiracetam dose has to be subsequently tapered off and patient remains seizure-free, and I was successful in this case. So let us think of another scenario. Now, patient is now seizure-free, but she wants to have a child. Will you change the drug regime? That's the next question. The drug regime need not be changed because lamotrigine is safe, but lamotrigine dose needs to be increased during pregnancy, especially during the second trimester, you may have to increase it like 20-25%. Dose has to be increased because of the larger volume of distribution. Now I am talking about an alternative scenario. The same primary generalized epilepsy patient, if the patient after lamotrigine and levetiracetam are put into action, and the levetiracetam continues to produce behavioral side effects, and the patient is still having seizure, and the diagnosis you have already asserted that it is a primary generalized epilepsy, what other options do you have? Now, this is probably a situation where the patient is just asking for valproate. Please give me valproate. So we have to give valproate. So now this is a female, so you don't want a very high dose of valproate. So we want to keep lamotrigine in the picture so that the patient can be on valproate, but on a smaller dose. So that is one option. But another option is that when the patient is on lamotrigine, generally we go up to 5 mg per kg. But when valproate is not there, you can go up to 8 to 10 milligram per kg. So these are the two options which are available in such a situation. Now think about this situation. This is another scenario. The patient was introduced on lamotrigine, patient has a rash. So what next to do? So that is what I'm trying to tell you, that the options are many. Now, sonizumab works well. Lacosamide is a drug which is recently approved for even use in primary generalized epilepsy, and perampanel can be used even in patients who fail valproate. And of course, we always remember when one or two drugs are failing, we have to keep valproate at a lower dose. Now, if the patient insists, this is another scenario, the patient wants to be on monotherapy, does not want to risk lamotrigine rash. Okay, you have to tell them, I'm going to introduce lamotrigine, there is a high risk of rash. Patient says, no, I don't want it. I will give you valproate. Patient says, I don't want valproate because it is going to interfere with my menstrual cycles and my prospects for a marriage and having a child. Then you have another option that is available is sonizumab. This is a weight neutral drug, sometimes produces weight loss, does not have much side effects, and then it does not produce a rash usually, but in long term can sometimes. Now, another situation. So I just want to emphasize how complicated, so dynamic decision making is best to tell you. Say the patient develops a resistance to valproate. Remember, if a patient develops resistance to valproate, if it is a primary generalized epilepsy, then it calls for some action. So you have to do a long-term recording for reclassification of seizures. In this case, we already showed the seizure recording, but if the video recording is not done previously, you reclassify the epilepsy. Second, sometimes you need genetic studies, but depending on family history, whether the patient has other seizure types. Always remember that failure on valproate is a sign of refractoriness, but all is not lost. You can still try lamotrigine, perampanel, and sonizumab. And other determinants of your choice would, as I told you before, whether the patient has migraine, patient is obese, whether patient has other seizure types, patient has anxiety or a mood disorder. Based on all these things, your choice will differ. So we can't say, okay, patient is primary generalized epilepsy, you give valproate. You see how dynamic the decision making is based upon the patient profile, the emerging situations and side effects and a whole lot of things. So this is just a new things, certain new drugs which have been approved. Now let's go to a clinical scenario, second scenario. This patient presented with absence-like seizures, but does not have idle myoclonia, limb myoclonus. She had associated behavioral cognitive symptoms, mild. And then she also has a family history. Now this patient is already on multiple AEDs. So this is an extreme scenario. Just to highlight that absences are not always easy to treat. We all always know that your patient comes with us absence issues. The first choice is valproate. But this patient is already 15 years of age. That is another thing. And then it is definitely not a typical childhood absence. So when you deal with absence, always be on the lookout whether this is another type of absence. So there is another patient similarly, which I have found recently. This patient had nearly absences throughout the day. So absences can be very subtle seizures. And whenever the absences are not responding to medications, we always try to record the events. And then, the patient was always in this state, always having that. And this is a typical, 3 hertz spike and wave. Here there are some poly spike and wave discharges also. So what I have found with absences is that not all absences will respond to valproate. So whenever absence does not respond to valproate, consider other options, ethosuximide. And this particular patient, we gave brivaracetam. Also, when absence does not respond, it's a good practice to see whether to classify the type of absence, what type of absence it is. I mean, Prashant will be discussing on these absences and childhood epilepsy, so I don't want to interfere with that. But very important to know the type of absence. You remember that there are new drugs like brivaracetam, sonacimab, valproate, ethoxyzumab, lamotrigine, phenobarbital, amantadine, all can be used in refractory absence epilepsy, even vagus nerve stimulation. Now, initially what we believed is that when a patient is introduced on a monotherapy, if the monotherapy fails, then you go for the second duotherapy, then a second monotherapy, then go for the first duotherapy, then second duotherapy. Although the principles are valid, because what we are trying to say is that we don't get into the habit of putting all drugs together in a patient. Our aim is always to not only to control the seizure, but also very important to keep the drug burden low. Very important to keep the drug burden low. So that is very important. So not just bombarding the patient with multiple drugs. So that is fine. But as I told you, when the first AED fails, you have to ask so many questions. What is actually causing the AED to fail? Is a patient compliant? Are the precipitating factors taken care of? Do we need to check the drug levels? And is the drug which we are using appropriate for the syndrome? Or what is causing the drug to fail? Is it a lack of epilepsy or unacceptable side effects? If the side effects are dose related or non-dose related. So if dose related, you can always de-escalate. But if it is non-dose related, it may call for change of the drug. So all these factors have to be taken into consideration. Remember, pseudo resistance should not be equated with true resistance. So you have to look at a lot of factors, disease associated factors, patient choice, patient factors, drug related factors. So the idea of combining two drugs is to get what is known as a synergistic action, where the efficacy is more than 1+1, and the side effects either cancel each other or at least they don't add to each other when you combine these two drugs. Very important. Broadening of spectrum is required not in all situations. So synergistic action is to be ensured. In efficacy and antagonistic action, or no synergistic or additive action in terms of side effects. So these are some of the drugs which have been in many human studies have shown that certain drugs can be combined better, like valproate, ethoxyzumab, vigabatrin, the tag. I mean, so many drugs, many of them are not very relevant to us. So I'll just like combinations which we generally use, like everybody knows about valproate, lamotrigine, synergism. Lacosamide, levetiracetam is synergistic. Lamotrigine, levetiracetam. Valproate, levetiracetam. So many of these drugs, they've randomly mentioned in different studies. I will tell you how I generally combine these drugs. And the first thing that you must remember that these patients who are on multiple drugs, when they come to you, your first, before choosing the second drug, your first thing is to get rid of some drugs which are not working. How do you get rid of a drug? That is the first, that's more of a challenge than introducing a new drug. So the first step is to get rid of the suboptimally dosed drug. Either you think, okay, the introduction of this suboptimally dosed drug has produced, if you think that drug introduction has produced the effect, then push it to the maximum dose. Either you push it to the maximum dose or the maximum tolerated dose, or you get it out of the way. The inappropriate drug should be the second to go. And the most side effect producing drug, the third. And then fourth would be an irrational combination. Then, so first to set the wrong things, take the wrong things out of the way before you set right. Okay, so we'll just go into a scenario to show this, illustrate this. So a 15-year-old girl presents with recurrent episodes of focal seizures due to hypoglycemic insult in the perinatal period. Age of onset was 4 years. She complains of darkening of vision, vague head sensation, ocular aversion, oculocephalic version, then tonic posturing, postictal vomiting and headache. These are brief events which occur about 4 times a month, and she's on 4 anti-epileptic drugs. So the first exercise, you look at the anti-epileptic drugs existing, you try to de-escalate and on. And always remember, when it's a drug refractory epilepsy, you have to do a video EEG recording. And first step in your mind should be whether this patient can be cured. Is the patient having a surgically remediable substrate or not? Okay, our discussion is not on that today. So we will go into rational polytherapy. Now, this just one case will tell you how that choice is made. It's very simple. You look at the presynaptic, the excitatory synapse, inhibitory synapse, then you go by it. Then you see whether the epilepsy syndrome which you are dealing with is specifically, gives you the option of selecting particular drugs. That's all. And then, of course, the age characteristics, the sex characteristics, and all those things. So you have a presynaptic synapse, the presynaptic neuron in the excitatory synapse. The best you have to attack the sodium channels because that is the most important. So in such a polytherapy, you should have a sodium channel blocker. So lacosamide, lamotrigine, oxcarbazepine. I would prefer lacosamide and lamotrigine compared to oxcarbazepine when it comes to posterior cortex epilepsy. Then you need a broad spectrum drug which with proven efficacy in refractory epilepsy and which can combine well with this sodium channel blocker. So either it acts on the GABAergic pathway predominantly like a clobazam, or it acts on the presynaptic neuron primarily like zonisamide, topiramate, brivaracetam. The first drug choice is going to influence the second drug choice. For example, if I chose lamotrigine as the first drug, I would either combine zonisamide or topiramate. And if I chose lacosamide, maybe I would go for a clobazam. And then comes the postsynaptic neuron. And in postsynaptic neuron, we don't have many drugs. And perimpanel is a drug, especially because the posterior cortex epilepsy, it's a refractory epilepsy. I would go for perimpanel. So perimpanel, zonisamide, and lamotrigine, or lacosamide, clobazam, perimpanel. So you have a logic to it, and you have to titrate the doses to maximum doses. And then only you will get the benefit. So if the patient continues to have seizures, of course, we have to go in for other non-pharmacological therapies. This is another situation which you may commonly encounter. This is a child who had a few seizures at 4 years of age, discontinued AED after 1 year, now presented with a flurry of seizures. So predominantly nocturnal events, 10 to 12 seizures per day. And there is asymmetrical tonic posturing followed by brief periods of restlessness. Now, what I'm trying to emphasize here is that when a patient comes with a very high seizure burden at the onset, or if there is a substrate on the MRI which tells you that this is going to be a refractory epilepsy, or there are certain other characteristics like genetic or say, which tells you that this is a difficult rate of epilepsy, you should not go by the usual algorithm of starting with a single drug, waiting for it to act. And many times when there is a large number of seizures occurring very frequently, use that opportunity to record the events in centers where it is possible and look for a surgical substrate and all. So main point is to start off with a combination rather than a single AED. And as I told you, combinations, you will find your own combinations. But some of the combinations which we use very commonly are, like as I told you, oxcarbazepine, clobazam, zonisamide, lamotrigine, topiramate with lamotrigine, zonisamide with perimpanel. These are combinations that work wonders and do not add too much side effects. So it's another child who came with again the same situation where a large number of seizures occurring, just within few days. Now this is a new thing which has come up in a recent paper also, which says that you don't have to wait for a long time to consider a patient for non-pharmacological therapies like epilepsy surgery. And I cannot close this discussion without emphasizing this, because my bread and butter, or the reason why I continue to be in this field of neurology is only because I enjoy classifying and finding out the right patient for epilepsy surgery, because this epilepsy surgery is truly life transforming. So when you are getting such a patient, you go by your monitoring, your video EEG monitoring. For example, this child had abduction of arms.
Can you have a minute left?
Yeah, it's about to finish. So there is an abduction of arms and a giggling sound. And then we record the events, you record the EEG, and you come to a conclusion that the patient has an epileptogenic lesion, which is confirmed by functional imaging as well. So very simple, you do an electrocardiography and resect and get rid of the lesion. It's an electrocardiography. So this is the final point which I want to emphasize, that the treatment gap is not only the patient's not receiving treatment, his patient's not receiving the ideal treatment. So you must always pursue ideal treatment and the best for these patients, because men bereft of hope can be restored to life, and epilepsy surgery is truly life-changing. So the take home measure is define your goal. And the goal is nothing less than giving them seizure freedom, good quality of life, and taking into consideration the expectation of the patient and family, and always keeping watch on the adverse effects. Hope is the anchor of the human soul. Never refuse it to a patient with epilepsy. Never stop trying. And don't go by one size fits all approach, because a customized, flexible, tailored approach always wins over dogma. And early identification of candidates for epilepsy surgery is the responsibility of everyone who is treating patients with epilepsy. So thank you for your patient listening. All questions are welcome. Thank you.
Yes, thank you, Sachin. It was an excellent talk. So we'll, because of the interest of time, we'll go straight to the next talk by Prashant. Prashant, please. Presentation. Screen sharing stop.
Yeah, good evening all. I thank all the organizers for providing me the opportunity. I also express my gratitude for Baiju sir for introducing with the nice words. Topic is epilepsy syndromes of childhood and adolescence. There are a lot of epilepsy syndromes, mostly they are described in childhood. So I will briefly touch upon the common epilepsy syndromes. What is an epilepsy syndrome? Epilepsy syndromes means important clinical construct. That means they encompass recognizable patterns. For example, if you see a patient with childhood absence epilepsy, if you see a video of a patient throwing childhood absence epilepsy or an EEG, then it becomes readily apparent that this is childhood absence. So that is what is meant by a recognizable pattern. Epilepsy syndromes are now organized primarily by the age of presentation. We have syndromes with infantile onset, those with childhood onset, adolescents to adult onset. So most of these syndromes are described in pediatric age groups. So my talk will be largely on those subgroups. So first about West syndrome. So West syndrome is the most common epilepsy syndrome of infancy, characterized by spasm, that is infantile spasms, hypsarrhythmia on EEG, and neurodevelopmental arrest or regression. Traditionally, it usually presents between 3 to 12 months, peaks at around 5 to 6 months. Traditionally categorized as cryptogenic or symptomatic. Some genetic disorders like tuberous sclerosis, Down syndrome have strong association. In our part of the world, West is often related to hypoglycemic, hypoxic brain injury and the multiple developmental malformations of cortical development. Multiple genetic causes like CDKL5, ARX, and a lot of other genetic factors are being identified as etiology to West syndrome. So clinically, it is a spasm. So sometimes there may be confusion between a myoclonic jerk and a spasm. Spasm comes in clusters, has some relation to sleep-wake cycle, and there is a tonic component to the spasm. And EEG indirectly, that is when the child is not throwing spasms, it shows hypsarrhythmia, which is a highly chaotic rhythm. And during the spasm, we get something called as electrodecremental response. At the beginning of spasm, there is a high amplitude spike and wave discharge, and for the next 2 to 3 seconds during the spasm, there is something like an electrical silence. So that is about West syndrome. Most common epilepsy syndrome in infancy is West, comes at around between 3 months to 1 year, peaks at around 5 to 6 months. It has to be identified early because delay in treatment can lead to developmental and epileptic encephalopathy. Now coming to Dravet. Dravet is a syndrome which presents usually earlier than 1 year of age. It presents as febrile hemiclonic seizures, prolonged febrile hemiclonic seizure. So child less than 1 year, along with the fever, child develops prolonged hemiclonic seizure on one side, consider Dravet. What is the significance of identifying Dravet? Sodium channel blockers like phenytoin, carbamazepine, that is lamotrigine, all presents in view of focal seizure. We may start them on sodium channel blockers, and sodium channel blockers can worsen Dravet. So importance in West is that if you miss it, child may go into encephalopathy. It is readily treatable or at least highly treatable. Dravet can worsen with the sodium channel blockers. So I leave the infantile syndromes there. Then we'll come to the childhood onset syndrome. Important syndromes are, one is benign epilepsy with centrotemporal spikes or BECs, and another syndrome called panhypopolous. Panhypopolous, that is self-limiting epilepsy with autonomic seizures. Syndrome onset between 3 to 6 years of age. Two-thirds develop seizures during sleep. Most prominent feature is an autonomic component. So panhypopolous, once the child presents to casualty, it may not be identified as a seizure itself because presentation is multiple vomiting, sweating, sometimes increased salivation, multiple autonomic features, diarrhea, all can be there, can be mistaken as acute gastrointestinal disease, sometimes as migraine, sometimes as the beginning of an encephalitis, etc. Generalized convulsions occurs in less than 50% of the cases. So importance of knowing panhypopolous is that it may be in a child 3 to 6 years, preschool child, it may come as recurrent vomiting and sometimes confused behavior, etc. It may not be diagnosed as a seizure itself. A third of these children have only single seizure. Long-term remission typically occurs within 2 years from onset, can be treated with broad spectrum drugs. Then comes to benign epilepsy with the centrotemporal spikes, also called as self-limiting epilepsy with centrotemporal spikes. It is again a common pediatric epilepsy syndrome. In fact, the most common epilepsy syndrome of childhood may be benign epilepsy with centrotemporal spikes. Seizures tends to be infrequent, up to 25% will have only single seizure. Usual age is after 5 years, peaks at around 7 to 8 years. The seizures are more common in sleep. It presents as a nocturnal focal seizure or GTCS in sleep. Involvement of face, tongue, etc. is common, hypersalivation is common. So what is the importance of identifying this syndrome? Though it presents as a focal seizure, they may have sometimes they may go into epileptic, something like an encephalopathy with addition of sodium channel blockers. So they are better treated, though present as focal seizure, they are better treated with broad spectrum drugs like valproate, clobazam, benzodiazepines, etc. EEG is almost classical, background is normal. There is marked accentuation of spikes in sleep, and it shows centrotemporal spikes, which are often bilateral, and something called tangential dipole. Sorry that it is not very clear there. So importance of identifying BEX is that it is common. It is a benign syndrome. MRI will be negative. EEG is diagnostic, and often they are treated with broad spectrum. Sometimes sodium channel blockers can cause a worsening. Long-term remission is usually attained by 14 to 16 years. Then epilepsy with myoclonic absence, also called as Tassinari syndrome, characterized by very I have videos of all this, but since it is going live on YouTube, I don't want to play it here. Characterized by very prominent rhythmic myoclonic activity during absence seizures. So in general, absence means we don't expect much of motor manifestations. In Tassinari, there's a lot of proximal myoclonic jerky. Like most other apart from childhood absence, most other absence syndromes are pharmacoresistant, especially G1 syndrome, Tassinari, etc. Tassinari also tends to be pharmacoresistant and has to be treated with the broad spectrum drugs. Another importance of Tassinari is that sometimes jerks may be very asymmetric and almost unilateral. So we may mistake it with the focal seizure. Actually, it is if you do EEG, it is a 3 Hz generalized pico discharges, and it is a generalized seizure. LGS, most of us have seen LGS. It usually presents after 1 year. Classic seizure is a tonic seizure. EEG shows poor background, generalized, slow generalized spico discharges, has structural causes, genetic causes. Again, treated with the broad spectrum drugs. Childhood absence usually occurs after 5 years. When an absence syndrome occurs before 4 years, we have to consider multiple causes of atypical absence, including root 1. Usually after 5 years, girls are more affected. Multiple episodes, brief lapse of consciousness, back and stare, behavioral arrest, fluttering of eyes, some automatism, and it subsides. Occurs abruptly, stops also abruptly, multiple episodes per day. Treatment point of view, childhood absence, 2 drugs to treat. Best drug may be ethosuximide. Valproate is almost equally efficacious, but side effect may be a bit more for valproate. Then lamotrigine, zonisamide also can be given. Levetiracetam has less effect in absence, maybe around 20 to 25%, less than half of what is seen with valproate. So even levetiracetam can be used, but effect will be less. So this is the 3 Hz generalized pico. I think Dr. Sachin also showed the same 3 Hz generalized pico discharges in childhood absence epilepsy. So if it is clear childhood absence, it is better to start on ethosuximide. If it is some other types of absence, it is better to start on valproate. Benzodiazepines and lamotrigine can be given. Then adolescent or adult onset syndromes. We don't have much of syndromes in adolescence to adult onset. One is nocturnal frontal lobe epilepsy. Autosomal dominant nocturnal frontal lobe epilepsy. Peak onset in early adolescence with variable age group. Symptomatology is hypermotor, multiple bizarre motor manifestations, pelvic thrusting, arm swinging, leg moving, etc. And sometimes this may be confused with a non-organic disorder because there is no total loss of consciousness. They do a lot of movement, hypermotor behavior. But the points to differentiate from a non-organic disease is that a typical FLE will be brief and it will be stereotyped. Even may not last long. Usually it lasts 1 or 2 minutes or even shorter than that. Whereas non-organic lasts longer. And it will be stereotyped. FLE will be stereotyped. That is, one event and another event will almost look the same. So brevity and stereotypy are 2 points favoring organicity in case of frontal lobe epilepsy. Symptomatic frontal lobe epilepsy, that is related to structural lesions like dysplasia, cavernoma, other vascular malformations, all may look just like AD and FLE. For that, we need good imaging, good radiologist, and EEG to differentiate. Sometimes, since it occurs in night, it may be confused with other parasomnia. So, importance of identifying AD and FLE is that it is confused with non-organic disorders and parasomnia. Treatment point of view, they respond very well to sodium channel blockers. So that is phentoin, carbamazepine, oxcarbazepine shows very good response. And if there is a confusion with the symptomatic frontal or non-organic or sleep disorder, BDOEG may be required. Then we have juvenile myoclonic epilepsy. Then coming to the last part of the talk, juvenile myoclonic epilepsy, onset usually in the adolescence. Most prominent clinical feature is a myoclonic jerk, predominantly involving the upper extremities, especially on awakening. When a patient is sleep deprived in the morning, develops a sudden jerk, things like pencil, brush, glass, etc. are thrown away. This is a typical myoclonic jerk of the JME. Early morning, sleep deprived patient developing a myoclonic jerk. Vast majority will develop additional generalized tonic-clonic seizures. Importance of identifying JME is that they have good seizure control, but often they require lifelong or prolonged course of drugs. If you taper early, they may develop recurrence. Valproate is considered the most effective drug for juvenile myoclonic epilepsy in boys and adolescent males. If it is girls and in the pubertal age group, it is better to give levetiracetam because of the teratogenic side effect of valproate. If you give sodium channel blockers, it can cause sometimes worsening of absences and myoclonic jerk. So it is important to identify JME because of two things. One, because of the treatment importance. Second, prognosis. They require long-term drugs. Then we have the last syndrome is MTLEHS, hippocampal sclerosis. Typical history is somebody with febrile seizures and febrile status during childhood, and a period during which there are no seizures. Then by adolescence start developing hypomotor seizures, characterized by aura of fear, rising epigastric sensation, etc. Subsequently, a hypomotor, behavioral arrest, vacant stare, automatisms, etc. usually lasts 1 to 2 minutes. So that is the importance of identifying. The importance of identifying the MTLEHS is that it is a readily treatable disease. First, we have to treat medically with the drugs. If drugs fail, if two appropriately chosen drugs fail, these patients has to be referred early for epilepsy surgery, because 90% of the well-selected patients of clear-cut hippocampal sclerosis undergoing anterior temporal lobectomy with amygdala appendectomy will become very good seizure outcome, almost class 1 angle, that is almost seizure freedom or only non-disabling seizures in 90%. So it is a surgically remediable syndrome. That is the importance of identifying MTLEHS. With that, let me conclude. Thank you.
Thank you, Prashant. It's a nice talk, and keeping the time, that was also very important. So only Prashant is available here. He can answer some questions if you want. Any questions? Prashant is an epileptologist in our city, so he can probably answer any questions if it is there. So if no questions, no, from this, you may be now knowing that how fast the things are advancing. Epilepsy, especially epileptology, in all subspecialties of neurology is advancing very fast. And a general neurologist or a sorry, there is a question. Where is that? Which is so Prashant, you can answer that. What should be the ideal current protocol for management of a seizure episode in a casualty?
Benzodiazepines IV, that is injection lorazepam will be the choice. After that, load with a drug, broad spectrum drug. Any drug can be given like phenytoin, levetiracetam, valproate, etc., depending upon the seizure type. If patient is already on a drug, then better load with that drug. Patient on juvenile myoclonic epilepsy on valproate develops drug default and a seizure, then better load with valproate to increase the levels, and can be similarly done for levetiracetam. So after benzodiazepine and levetiracetam, and seizure crosses more than 5 minutes, then we will have to call it the status epilepticus. At that point, give one more IV drug, and if the seizure fails to remit, then give put the patient on ventilator and start on anesthetic drugs if needed.
Second question is about the dietary modification. Any dietary modification?
As such, there may not be dietary modifications as such, but ketogenic diet may have to be implemented in some children with refractory epilepsy, which occurring from LGS, do say it is a treatment of choice for GLOT1.
Pregnancy, seizure, and ideal.
Ideal drug may be levetiracetam. Lamotrigine also can be given. And the problem is teratogenicity. Teratogenicity is related to the dose of the drug. Even valproate less than 200 milligram may be safe. Valproate 200 milligram and high dose lamotrigine may be almost equal to teratogenic. So depends on the dose. But in general, levetiracetam and lamotrigine are considered the safest and valproate is considered the worst.
So because of the interest of time, I think we will finish here. So we had two brilliant talks today evening. And as I was talking about that, now you may be having some idea how fast the things are going, like the epilepsy management as it, even for the general neurologist or a neurologist in another subspecialty, it is difficult to now cope up with the fastness in which the epilepsy treatment is going on. So the first talk was mainly about the choosing anti-epileptic, the mainly art, no, as in medicine, any part, any other field of medicine also, the practice is an art rather than a science, or a beautiful blend of art and science. So to conclude, for mainly for the general people, practitioners around, what Sachin was highlighting was about the patient-related factors and the drug-related factors, which are important for choosing the right drug. So, and both we have to consider, like for example, the patient-related factors, as he has mentioned about the age, the sex, particular time of the physiological period, like the pregnancy, a lot of that, and old age, all those things are important. Like that, in our part, he was mainly talking about the drugs, like the newer drugs, like the lacosamide and lamotrigine and levetiracetam. For our part, now in a general neurology perspective, another important problem is their affordability also, the people's affordability, and other social taboos also, multiple drugs, the drugs causing side effects and all. They also come in the picture. So here another point is the epilepsy syndromes also. He was mentioning the patient-related factors. The epilepsy syndromes are also important. The epilepsy syndromes, Prashant has already discussed in detail about that. The epilepsy syndromes are clinico-electrical syndromes where you have some guideline, which drug is better for which. So the identifying those syndromes are very important. As even though Prashant has rushed through it, this is a beautiful talk. Actually, he has presented some 1 week back in another forum, which was very nice. Actually, he has rushed through, and that is why actually most of the things he had to skip the videos and all. It was a very nice talk. Now coming to the drug-related factors, they are also important. Now the drugs, as Sachin has mentioned about the older anti-epileptic drugs, newer anti-epileptic drugs, like the lot of drugs and newer and newer drugs are coming in the pipeline also. So for a general person or a general practitioner, it is very difficult to cope up with which is the drug which is to be given to a patient and all. So now we know that in all casualties, emergencies, the people will be giving levetiracetam left and right. No, so it may not be a good drug. You have got some other good drugs which is better. So the most important thing in newer anti-epileptic drugs is the side effect profile is better. So when you are having a newer drug, it is a better side effect profile. So this is the way actually you have to choose. And then about epilepsy syndrome already we have. So anything else? So from our side, for myself and my co-chair, thanks IMA Thrissur branch for giving us this opportunity to chair the session and this giving us a beautiful evening. Thank you very much.